I'll present to you about early life influence and the prevention of food allergy. So in early life, there is multiple factors. There is the genetics, which it's there and it's fixed, and there is the exposure to the allergen to the fetus through blood, through amniotic fluid, cutaneous later on, and through breast milk. And then there's the environmental, the diet, the maternal and the baby diet, the pollution and the microbes, and all this cause what's called epigenetics. And then either the fetus after born, either he get tolerance, small T regulatory cells, or get skewed to more Th2 cells. In regard to prevention, there is multiple strategies has been tried antenatally during fetus life, and using restriction diet for the maternal, using other supplement. There's the strategies after born during breastfeeding, and strategies for infant in regard to diet restriction and supplementation, and the use of other supplements like probiotic and prebiotics. So let's go on start with the antenatal strategy, maternal diet. We all know that maternal diet allergen does cross the placenta. It also passes through the breast milk to the fetus. And it has been shown that inhalant and food antigen, specific IgE, and the blood reflect actually maternal IgE. But if you follow up those babies at 6 months, you found that those IgE antibodies disappeared. So probably sensitization does not completely occur during utero. So my focus is in preventing food allergy, but I will allude a bit on other allergic diseases. So maternal diet restriction, the meta-analysis showed that there is no effect in terms of preventing atopic asthma, atopic dermatitis. Same thing with atopic asthma. In regard to food, and this is in particular to egg allergen at 6 months, there is some effect, but the p-value wasn't significant. And at 18 months, the maternal restriction diet did not show any effects. As you can see, the diamond is at nearly at 1, no effects. Not only that, also the meta-analysis showed that there was slightly statistical significant lower mean gestational age on those babies from mother-restricted diet. And also they were, although non-significant, but they were high risk of preterm and high risk of reduction of birth weight. So the recommendation, as you all know, that does not recommend any diet restriction for the mother during pregnancy. So how about supplementation? This was in the news just last year in the BBC about fish oil and probiotic, and it was basically it was announced after a publication by Boyle and meta-analysis by Boyles and others. So fish oil is known to have its effects on immune modulator of the fetus, neonate, and infant. Also, studies showed that related immune parameters were lower on babies from mother taking fish oil compared to babies and not on fish oil supplement. And they were also shown some associated of balanced Th1 and Th2 and modulating interferon gamma and IL-12, IL-13 on infants. Another thing we also know about supplementation of fish oil or omega-3 during pregnancy, that the eczema was less diagnosed on those babies from mother receiving, taking supplementation during pregnancy compared to mothers who are not taking fish oil supplementation. So the Australian guidelines actually in 2016, they have it in their recommendation that mother can take 3 servings of fish oil weekly, and it was shown from the recent data that is benefit in decreasing eczema in early life. How about preventing food allergy? The meta-analysis by Boyles showed that in this shows any food, pool effect, and milk and eggs and peanuts. Basically, the most effect was shown in the eggs, that it does prevent desensitization of egg, but not actual allergy. It wasn't studied to look at the actual allergy, but it does decrease 30% reduction of egg sensitization on 1 year on babies from mothers taking fish oil during pregnancy. Probiotics, my colleague from Dammam, he presented very well, but as you know, they are live microorganisms. But all the studies use either single or double or more than one, multiple organisms. It's either capsules or powder or part of a drink. And the dose varies from 1 to 10 billion doses. So there's significant clinical heterogeneity in the clinical trials which you looked at probiotics. So in terms of using probiotics and preventing desensitization, the meta-analysis showed that it does not have effect in terms of egg desensitization. It had some effect in milk with a pooled relative risk of 0.59. So when it comes to breastfeeding, the mother and diet restriction, 2 randomized controlled trials showed no evidence of diet restriction during lactation and preventing food allergy. In regard to probiotics with breastfeeding, there was 1 randomized study showed also no benefit evidence. And fish oil as well showed 2 randomized trials showed that there is no benefit in taking fish oil and preventing food allergy in offsprings. So how about primary prevention for kids? So the first thing is the use of hydrolyzed formulas versus standardized formula. Earlier observational studies showed that atopic manifestation was significantly reduced during the first 6 months when only hydrolyzed formula was administered comparing to standardized formula. Another, in 2003, published in JACI, a very large cohort from German Infant Nutritional Intervention Program showed the incidence of allergy was significantly reduced by using hydrolyzed formula compared to standardized formula with an odd ratio of 0.51. But recently, Robert Poyles and others published in PMG in 2016 a meta-analysis for the hydrolyzed formula and for the extensive hydrolyzed formula. So you can see that using hydrolyzed formula from pooled effect from randomized control trial, it showed no benefit in terms of preventing atopic diseases in later in life. In terms of using extensive hydrolyzed formula, there were only 3 studies. The clinical heterogeneity was very significant, 77%, but the pooled effect was also did not show any benefits. As you can see, the diamond, it's very wide with a wide confidence interval. So from this study, they show that there's no evidence to support the protective role of using partial or extensive hydrolyzed formula. And their conclusion was that their finding does not follow the international guidelines of using hydrolyzed formula, which is recommended for high-risk infants who are not on breast milk. So seems that the Australian guidelines are on top of things. So their guidelines, it's only guidelines actually, as far as I know, that they mentioned that based on recent publication that there's no prevention in eczema or food allergy or asthma in infant using hydrolyzed formula compared to infant using cow milk allergy. In terms of breastfeeding, systematic reviews, all in most showed that it has a protective effect in atopic diseases. So the recommendation is to exclusive breastfeed until the age of 4 months. In terms of avoiding allergens, the previous recommendation, as you probably all know, used to recommend cow milk avoidance at 12 months, egg avoidance at 24 months, and peanuts and nuts and shellfish avoidance until the age of 3 years. This has been found that not effective, and contrarily, there was increase in food allergy in the last decades. And basically, this was based on observational study. The first one, which is the famous one published in JACC in 2008, where they looked at two populations, a population where they introduced peanuts early in life and another population where they delay the introduction of peanuts. And they found that those who delay the introduction of peanuts, they had a more incidence of peanuts allergy later in life compared to those who consume peanuts early in life. This was also shown in other studies in cow milk and in eggs. In cow milk, the mean age of cow milk introduction was significantly lower in healthy infant than those with IgE mediated. So those who are introduced early on to milk, they have more protective effect in developing cow milk protein allergy. In terms of egg, another observational study showed that introduction of egg into the diet later in life was associated with a higher risk of egg allergy compared to those who introduce egg early in life. So the guidelines revised, and it was out that there is exclusive breastfeed to 4 to 6 months, and there is no recommendation against avoiding any allergenic food. And the idea comes that how about introducing the allergenic food, like doing it as an intervention to prevent food allergy. And this idea came that the food, when it's taking orally, it goes to the digestive system, it gets digested, and then it introduces the immune system not as a whole protein. So the antigen-presenting cell will present that peptide to the T cells. T cell will proliferate in the presence of a T regulatory cytokines and produce the antibodies which against allergy. Whereas if the patient has atopic eczema and the allergen go through a breaking skin, it will be as a whole protein, and this will stimulate the taking up by antigen-presenting cell in the presence of Th2 cytokines, and the B cell will switch to produce IgE, which is causing the allergy. And compared, if you have an intact skin, no eczema, so the protein will not be penetrated. So the idea said, if we early feeding intervention, can we avoid food allergy and cause tolerance in healthy or in eczema or in kids with eczema? So the LIP study came out, learning early about peanuts in 2015 in New England Journal of Medicine, and showed basically in the intention to treat analysis, significant difference between those who consume peanuts early then compared to those who avoid peanuts. And then there's a subpopulation, those who are synthesized early on, the skin prick test was positive. It also showed that those kids also had a significant difference than the population, and if you put the whole cohort together, it showed a significant p-value. When they look at the per protocol analysis, so those all the kids who follow the protocol strictly and complete the study, it also showed that it was significantly associated. And when they did the worst case scenario, so all the kids who lost follow-up or they cannot judge the outcome, they put them in that they did develop the allergy, and it also showed significant difference. So their conclusion that early introduction of peanuts will lead to avoidance of peanuts allergy later in life. This was followed up in another study, but those on healthy kids. The previous LIP study was in kids with eczema. This is in healthy born babies, the EAT study. And in this study for peanuts in particular, when it comes to the intention to treat analysis, the p-value was not significant, but it was significant in the pair protocol analysis. This wasn't a blind study, so it was an open label study. So that was a defect in the study. When it came to meta-analysis, they put those two studies together, and it showed that there is a significant pooled effect of 0.29. So there's about you are preventing 70% of the kids to develop peanuts allergy, and with a significant p-value. So in 2017, they published an addendum to the food allergy, to the American Academy of Food Allergy guidelines, and they put 3 addendums. So if you have a child with severe eczema or egg allergy or both, they strongly recommend that you do an IgE test, either blood test or RAS test, and accordingly, you introduce peanuts between 4 to 6 months to avoid peanuts allergy. If it's mild to moderate eczema, you introduce peanuts at a normal 6 months. And if there is no eczema, you introduce the peanuts as appropriate to the age. So they developed this diagram where if you have a severe eczema or egg allergy or both, you can either go for an allergy test, RAS test. If it's negative, you go and introduce peanuts to the kids to prevent peanuts allergy. If it's positive, you refer them to an allergist. If you do a skin test, 0 to 2, you introduce, and it's 0 to 2, you introduce peanuts at home or in the office. If it's 3 to 7 millimeter, you do it in your office just to be cautious. And if it's more than 8, probably the patient might have peanuts allergy, so you need to follow him up. In regard to meta-analysis for introducing milk, for milk, there were 2. Birking, the earlier New England Journal Medicine, the one I present for peanuts, was healthy babies, and Loy. Both studies showed that there is no significant, either in terms of sensitization or in allergy, or allergy preventing later on if you introduce cow milk early. In terms of eggs, there was early meta-analysis published, looked at eggs, and then together with Dr. Surveget from Iceland University, we conducted a meta-analysis looking at introducing egg and the developing of egg allergy. So if you look at the studies, we found 6 studies, Palek from Germany, Nutasumi from Japan, Palmer, 2 studies, 2013, 2017 from Australia, and Perking from United Kingdom and Australia. You can appreciate that there were clinical heterogeneity. The patient population are different. 4 studies was done in healthy infants, and 2 studies were done in infant with eczema. The other difference is the first degree relative with asthma was about 60 to 100%, and the number of participants with eczema was ranging between 0 to 100%. The intervention were either raw egg or heated eggs, and 2 studies were heated, the rest of the study were raw eggs, and there were also a difference in the amount of egg used. And it ranged from as small as 350 milligram twice a week in the Japanese study, and up to 700, 500 in Palek study from Germany. Their comparison were all placebo except for Perkin, which was exclusive breastfed babies, and they all looked at food allergy as their primary outcome, allergy food challenge test as their primary outcome, except for TAN, which looked at the primary outcome was egg sensitization, and TAN did oral allergy, but as a secondary outcome. Their follow-up all were 1 year, except for Perkin, they did the assessment at the age of 3 years. So what was the pooled effect? As you can appreciate, Palek study showed harm rather than benefit. The other studies, they all include the one, so they all had non-effect or so basically none of them were significant except for the Natasumi study, which showed significant effect, which was published in 2017. But the pooled effect, the p-value was significant in terms that there is an association. If you introduce egg early in life, you might prevent egg allergy. So we went and took it further. We did the subgroup analysis looking at the dose. As I mentioned, there were different doses. We used the cutoff of 4,000 milligram per week. And we found those, and we excluded 2 studies which use heated eggs because that might affect the antigenicity. So all those 4 studies use raw milk. It showed that using a high dose, which is 4 grams per week, showed no significant difference. And using a low dose, 4 grams per week, showed that there is a significant difference. But this is only from 2 randomized controlled trials. So our conclusion was from that meta-analysis that there might be an association between early introduction of egg and the preventing of egg allergy. There was 1 study out of the 6 which showed significant unequivocal benefit, which is the Natasumi study. But keep in mind that the Natasumi study, they used a very low dose. They start with 250 milligram, and then they increase it to 900 milligram. So there is a questioning if they are doing something close to immunotherapy rather than primary prevention. There were considerable clinical heterogeneity, as I mentioned, between the 6 studies. The dose might be something to look at in the future studies which will look at early prevention of egg allergy. So in summary, finally, there's multiple life factors which influence the developing of food allergy. So far, the evidence showed that some strategy proven to be ineffective, which is delaying the allergenic food to infants. Some other intervention likely to be useful, such as likely to be unuseful, such as changing or restricting maternal or lactating mothers. Other might be promising, like supplementation with probiotic, prebiotic, and omega-3 for pregnant women and breastfeeding and the prevention of food allergy. And the intervention with early exposure to allergen like peanuts proven to be effective, but still for other foods are still not proven to be effective.